I'll be talking about surgical planning in strabismus. I do not have any financial interest to disclose, although we are always looking out for some. And before we start our surgical planning, some of the tips we've already discussed, but it always helps to be a little sharper in our pre-surgical workup. So I'll just highlight some of the key things. Accommodative esotropia is something that will be discussed subsequently as we talk about esotropias, but always remember just a refraction can change the entire management, and age-appropriate cycloplegic refraction is essential. And in many cases, in young children, the esotropia may just get corrected with glasses and there would be no need for surgery. Divergent squints, if you thought that may not really make a difference, refraction would not make a difference, it's important to note that fusion in a divergent squint or even in exophorias is the key responsible feature that helps us to control strabismus. And that is essentially possible only if we give high quality images on the retina. So a good refraction, increasing the quality of vision, will help to control the fusion and help to control the exotropia. So intermittent divergent squints may become an exophoric if you give them appropriate glasses. We've talked about evaluation and managing amblyopia, and it is extremely essential that we manage amblyopia before we operate. There are too many advantages for this. Firstly, you are wasting time that could be essential for amblyopia therapy. If you start amblyopia therapy after surgical correction, especially patching, there is a possibility that what you converted atropia into aphoria may redevelop. So you may have a recurrence of the squint, as well as parents and children do not feel that there is any actually problem with the eye because they don't keep checking the Snellens at home. So they may actually lose interest and stop coming back to you. We know that children are far more intelligent than us, and they find excellent ways to evade any therapy we may give. So it's always important to interact and to discuss the possible treatment with the parents and the children. A lot of other lesions can present as strabismus. We've had possible children presenting us with early onset strabismus, which we thought was infantile in origin, but it landed up being an acquired cause. So it's always important to definitely rule out an acquired strabismus. And if there is even a little bit of suspicion, work up towards that. Again, variability is something in an older patient, recent onset, variability can be imminently possible. And myasthenia, being the great mimicker that is, could present with any kind of strabismus. Always be sure of your diagnosis because you don't want to operate something thinking that it is something else. Duans and sixth nerves are often missed or interchanged, and it's very important to identify a Duans because you would not want to do large lateral rectus resections for the esotropia that is there. So it's very important to pick up Duans as a possible differential of sixth nerves. Again, pseudo-esotropia. The parents may feel that there is an esotropia, but look at the corneal light reflexes. From afar, the child may look esotropic because of the adnexal positions, but the moment you shine the light, you'll realize the corneal light reflexes are centered. Ask the parents to take photographs at home, repeatedly using a flash so that you can look at it. And of course, it's very important to follow up these child because nothing precludes a child with pseudo-esotropia to subsequently develop a true strabismus. The factors that affect our amount of surgery we are planning is the angle kappa. So it's important to have an idea of the angle kappa. Look at the eye when it's at a distance target and look for pseudo deviations that may be there. So the distance deviation, either eye or apparent deviation, is important. Look at the adnexal relationships, epicanthal folds, hypertelorism. Inform the parents that this is not something that will be corrected, and there may be for some time an apparent squint which will get corrected as the child grows. Look at the eye movements, both versions and ductions, and look for limitations because they need to be managed before you intervene. So FDT has to be done both pre and intra-op. And finally, what is your sensory state you're looking at? It's cosmetic, functional, you want to overcorrect and manage oblique overactions. Graded weakening procedures of the recti are recessions with their various modifications like hangback, adjustable, slanting recessions. Other than that, for recti, there is not too much of an option. You would not, I mean, Farden is a procedure, a weakening procedure that weakens the muscle in the direction of action, but otherwise free tenotomies, myectomies are only described for obliques. And even there, we would prefer to do a graded procedure as compared to a free procedure. There are upper limits for both recession and resection. Going beyond a particular amount would weaken the muscle and would cause gross movement under actions, limitation of movement, which would be extremely difficult to manage post-op, and the patient may complain of diplopia and horizontal gazes. Large recession resections can actually cause palpable fissure changes that make it uncomfortable for the patient. Again, for the recti, graded resections or now plications are the procedure of choice for strengthening procedures. Advancement is possible in a previously recessed muscle, and tucking double pressing is possible for superior oblique. Transposition procedures are planned if there is a very poor muscle action in any of the muscles. Again, maximum resection is limits for maximum resection for every muscle is there, because the moment you start cutting beyond a particular amount, you start cutting myofibrils, which will actually add to the weakening process rather than strengthening it anymore. There are described gross nomograms for primary surgery. Use them in your initial decision making, but over time, because of the variation in the way you operate, you may have a little difference in the outcomes, and you must alter your surgery according to your differences. There is a lot of options between bilateral recession and unilateral recess resect. The advantages of a recess resect procedure is that you get an added effect of almost 25% in a one-eye surgery, which is not possible in a bilateral recession. However, a bilateral recession, of course, causes less inflammation, less edema. The eyes look similar on both sides. Therefore, the palpable fissure changes are not so much as there is for a unilateral recess resect procedure. So in an adult where it's difficult to block both eyes, we prefer a recess resect versus under GA, which is a bilateral procedure preferred. We know that recessions are stronger than resections, and we get a larger response in the medial rectus compared to the lateral rectus. We get 25% more effect if we operate one eye, and much greater impacts on infants. Like I said, do not induce incompetence. You can divide the surgery between the two eyes, be consistent in what you do. Factors that affect outcomes include age, patient response, and larger deviations create a much larger response. So the amount of surgery the change in the amount of surgery should be graded accordingly. Placement of sutures, the amount of muscle exposure, dissection, all these are surgeon factors. So it's very important to be consistent in whatever way you do, where you hold the muscle, where you start the measurements from, and where you pass the sutures, because they make a difference. There is no significant difference in outcome in both limbal and Fornix incision for the same amount of surgery, and it is a surgeon preference, although Fornix incisions are faster, cleaner, and cause less early problems, but limbal incisions are equally good and probably better for beginners. So our decision is also affected by what we are operating and our endpoints, and that will be discussed in the competent surgery we're talking about. You must measure A and B patterns because it's important to incorporate that and operate for the obliques if obliques are overacting. And if obliques are not overacting, you need to shift the muscles and correct for the A and B patterns in your primary surgery itself. So the important take back thoughts are: nothing can alternate a good workup, correct diagnosis, and realistic expectations. And you need to be very clear and confident in what you do and discuss everything with your patient all the time. Thank you.